Hey guys, so I have decided that we're going to just do a screencast for the remaining 6 slides in normal physiological pregnancy changes. So we left off with the positive indicators of pregnancy, and I shared with you that these positive indicators are the only way to truly know somebody is pregnant. So knowing the difference between the three categories, possible, presumptive, and positive indicators is really, really important. So the positive indicators were actually auscultating those fetal heart sounds, the provider, so nurse, midwife, OBGYN, feeling the movements of the baby, and then actually visualizing the baby on an ultrasound, which is indicated below. Sorry guys, let me figure out how to, okay, here we go. So in terms of fetal movement, now this is outside of the realm of those positive indicators. This is just, again, the normal pregnancy changes. If we are working with a woman and she asks us, when am I going to feel my baby move? It's often called quickening in our nursing and medical terms. We call that fetal movement quickening. A woman who's having her first baby, a prima gravida, will feel her baby move around 20 weeks. Her husband or her significant other won't be able to feel it at 20 weeks. She'll be able to feel it internally. It takes about another 1 to 2 months for somebody to feel it by putting their hands on her belly. For a woman who's had a child before, she's going to start feeling her baby move at about 18 weeks. When a baby first starts moving in somebody's uterus, it feels like butterflies is how women describe it. I'm going to describe it for you from my experience with 2 children, is that it feels like a fish flopping and gasping for air. So not so much the gasping for air, but if you imagine a fish out of water and how it's just sort of flip-flopping, that's what it felt like to me the first time I felt my children move when they were in utero. Okay. What do we do for women when they're pregnant? So the preconception visit, right, we spoke about a couple of classes ago when we talked about preconception care being arguably the most important aspect, because that's when we do information on genetic testing. We also talk to women about taking folic acid. Remember the 0.4 milligrams of folic acid to prevent neural tube defects. So we'd like them to get a preconception visit for all of those things. But then once they are pregnant, they come in for their first prenatal visit. We do a history with them, full history. We talk about their past pregnancies, and we were talking about that today. Their history is important. Did they have a big baby in their last pregnancy? Did they have diabetes in their last pregnancy? We want to know because that will tell us what they're at risk for this pregnancy. Vital signs, a physical exam. So they come every month for these visits until they hit 28 weeks, which is the start of the 3rd trimester. Then they're going to come every 2 weeks until they reach 36 weeks. And in that last month of pregnancy, so from 36 weeks until they're 40 weeks or whenever they deliver, we're going to see them every week. The importance of that is that women could develop high blood pressure, something called preeclampsia. Women can develop complications that last month of pregnancy, and that's why we see them so frequently. At those visits, at all these visits, we always take women's vitals. We always do a urine dip on women when they're coming in. We are checking for sugar and we're checking for protein. If we see protein in a pregnant woman's urine, we're worried that she's trending towards preeclampsia, which we're going to talk about as a complication of pregnancy. All right, the trimesters we detailed out the other day, right? The first trimester is 1 to 12 weeks, and then the second we've got about 13 weeks to 28 weeks, and then the third from 28 all the way on up till 40 or when she delivers. All right, a woman comes in and gets blood work when she's initially pregnant, right? We talked about the fact that she could have a physiological anemia, so we want to know what her H&H is. We want to know her blood type. We want to know her Rh factor and whether or not she has any antibodies. We are going to talk about women who are Rh negative. So let's say they're A negative or B negative. So women with a negative blood type, so that are Rh negative, will need something called RhoGAM when they get to 28 weeks of pregnancy, and then also after they have their babies, if their babies are Rh positive blood type. And again, I'm going to detail that in depth in a couple of weeks, but just know if a woman's blood type is, her Rh factor is negative, we want to make sure that she has gotten RhoGAM during pregnancy, and we will assess whether or not she needs it postpartum. VDRL and RPR, those are 2 different tests that test for the same thing, syphilis. We also do a hepatitis hepatitis surface antigen to check for hepatitis in a pregnant woman. We also do 2 HIV tests. 2 HIV tests is imperative, one early on in pregnancy and one again towards the end of pregnancy. I want somebody to remind me in class that I'd like to start on Thursday after we take our quiz with sharing with you the importance of 2 HIV tests. UA is a urine analysis. PAP is a pap smear. We do those at the start of pregnancy if a woman is due for a pap smear. GCCT is gonorrhea and chlamydia testing. Really important that we test women for gonorrhea and chlamydia. We'd want to treat them if they had either of those STDs. Genetic testing that we'll speak of is really on a PRN basis, so we give the woman all the information, and her family make the decision of whether or not they'd like to be tested for genetic disorders. If the woman is at risk for TB, she would get a PPD to ensure that she does not have tuberculosis. And then later on in the pregnancy, she would have, at 28 weeks, she has a 1-hour glucose test. That's a screening test for gestational diabetes that all pregnant women get. And then when she gets to be 36 weeks, and when she's in that last month of pregnancy, she has her group B strep culture swab, which gets swabbed in the vagina, on the perineum, and right outside the rectum to test for group B streptococcus. All right, so risk factors for pregnancy. I want you guys to go ahead and fill this in. Women who are on the young and older spectrum are at risk, so teens, and then women who are greater than 35. Socioeconomic status, obviously women who are of lower socioeconomic status usually don't have access to nutrition and good prenatal care in the same way that other groups of women do, so they are at risk. Social history, right? We can think of women who have drug addictions. We can think of women who are in unstable relationships and even abusive relationships. Past OB history, we've touched on this. Women who have had macrosomic babies in the past, which is a large baby. Women who have had diabetes in the past. Women who have had complications during their delivery. Women who have had C-sections. Women who have had preeclampsia. And then medical history. If the woman has high blood pressure, if she has high cholesterol, if she has diabetes going into her pregnancy, all important things, whether she's had surgeries before, especially other surgeries to her uterus. So go ahead and fill that in from your text. All right, these are things that we've talked about in class, and they're teaching points for pregnant women. So we want to teach women to avoid going into hot tubs and saunas. We talked about we don't want women to raise their core body temperature. That can be dangerous for the developing fetus. We want to be sure that we're not that a woman isn't engaging in intensive exercise and really increasing her heart rate. So by that I mean, if a woman is not a runner, she should not be training for a marathon when she's pregnant. However, if you have a pregnant woman who is a runner, she can continue to exercise at that capacity. So it's not a time to take up marathon running. However, if you're somebody who is already an avid swimmer, somebody who is already an avid tennis player, whatever it is, the woman can continue with what she's doing. I just don't encourage a brand new vigorous exercise plan. I do encourage exercise for sure during pregnancy. It helps with maintaining a normal weight gain during pregnancy, and it also makes for a healthier pregnancy and an easier delivery for women who are exercising. Obviously, because of the pressure on the vena cava, we don't want women to lie supine. We want them to avoid exposure to chemicals and teratogens, which we spoke of. We don't want women to douche during pregnancy. We want to make sure that she's avoiding unpasteurized cheese, uncooked fish. She can eat fish, however, it has to be cooked. And we recommend thin, white, flaky fish. Thicker fishes have higher mercury contents, and we don't want her to have high mercury. We don't want her to smoke, use drugs, use alcohol, and we also want her to check on whether or not it's safe to take over-the-counter medications. All right, but we do want to remind our pregnant women that it is okay for them to have intercourse, right? Sometimes if we don't say that to women, they and their partners may think, well, maybe we shouldn't. So it's important for women to know, as long as they have a normal, healthy pregnancy, it is okay to have intercourse. I write here, if they were to have something called placenta previa, that would mean that their placenta is developing over the cervix, and if they were to have intercourse, they would have bleeding. So we recommend if somebody has a low placenta previa that they do not have intercourse. If somebody's at risk for preterm labor, right, we know that in general, when a woman has an orgasm, that her uterus contracts. This is a woman who is or is not pregnant. So if you have a woman who's now at risk for having her baby prematurely or early, and we know that intercourse in and of itself causes the uterus to contract, now she's pregnant and at risk for preterm labor, we wouldn't want her to be having an orgasm and causing her uterus to contract. So we'd have her avoid intercourse altogether. And then once a woman's membranes rupture, right, ROM, we wouldn't want her to have intercourse because remember the baby at that point is at risk for infection, okay? So the baby's no longer in the amniotic sac because it has ruptured. So no intercourse at that point. Exercise, I write here swimming is best because women feel very buoyant when they swim. It's a great form of exercise that's using her whole body. But really, if a woman isn't a swimmer, she can walk. Whatever exercise works for her. We just want her to stay moving. All right, common discomforts of pregnancy I have here, right? Women will complain of stretch marks. The over-the-counter creams, if she likes them, she can use, but nothing is going to prevent those stretch marks if they're coming. Constipation, we do want to help to treat. We can tell her to increase her water intake. She can take Colace if she needs to. Hemorrhoids are often a side effect of her being constipated. She can use over-the-counter medications for those hemorrhoids, but that can happen. Back pain, right? We know lordosis is happening. We know that the gravid, right, the pregnant uterus, that's called a gravid uterus, is going to cause her some back pain. The nausea was caused by all the progesterone that's maintaining the pregnancy, but nausea can occur. Things she can do for nausea are eat small, frequent meals. I know this sounds counterintuitive, but keeping her belly full decreases gastric acid, and by keeping her belly constantly, not a full state, but with something in it, will help make her feel less nauseous. So again, that's something you have to explain to women because it's counterintuitive. Vitamin B6 is something a woman can take to help with nausea. Another thing she can do is get C-bands, which are sold over the counter for motion sickness, but those go a long way to help women with nausea. And dehydration, we want her to stay hydrated with water. All right, these are very important things that should a woman experience or tell you is happening during her pregnancy, that these are danger signs of pregnancy and she needs to call her midwife or her OBGYN immediately, absolutely immediately. So these are the danger signs in pregnancy, okay? So any vaginal bleeding, any fluid leaking from the vagina, these obviously, if she was near delivery and she has fluid leaking from her vagina and she's full term, then great, we may be thinking she broke her water. But if she has bleeding or fluid leaking from her vagina earlier on, before term, this could be a sign, a very dangerous sign that she's in premature labor. These next signs that are grouped together are signs of preeclampsia, which is a severe complication of pregnancy that, again, we're going to discuss. This headache is usually frontal, so behind somebody's forehead. These visual changes people describe as fireworks going off in their eyes. And epigastric pain is because when somebody has preeclampsia, their liver is inflamed, so they have this pain off to the right because of the liver being inflamed. And then the remaining signs, danger signs down here that are listed are pretty self-explanatory. If the baby isn't moving well, we're worried about a fetal demise. So we always want a woman to report if she's not feeling fetal movement. And then this last point, the contractions before 37 weeks, speaks to we really want women to be full term when they're having their babies. Better to be at 39 weeks, but once she hits 37 weeks, if she goes into labor on her own, we're not going to stop it. But if she's before 37 weeks, we do need to try to stop it because those babies' lungs are not developed yet. All right, so I will answer any questions. This is a great visual again on how much the body changes during pregnancy. The remaining slides I want you to hold on to when we talk about the psychosocial changes of pregnancy and postpartum. That's what the remaining slides are for. Thanks, guys.